Hello friends, it's from Dynpaths and today we'll be talking about the further on moving the discussion of the fundamentals of cell injury. Okay, let us share the screen now. See friends, last discussion we have talked about the some principles of the PaO2, P small aO2 and O2 content. We said that uh, diffusion of all those things will affect the oxygen saturation. So to understand how a cell injury will happen, we have to understand first we have to understand what can cause, what can lead to hypoxia, because we said oxygen is important for the metabolism of the cell, and if the oxygen is not present, cell will lose its cell will start getting acidic and all those things will start initiating. So in tissue, to understand the fact that how oxygen is getting, we have to understand what things, what factors can cause tissue hypoxia. And we know the definition of hypoxia, I hope so, from the previous discussion, that it is the inadequate oxygenation. So we are actually talking about the oxygenation status of the tissue. We are actually talking about the oxygen. Whenever you think of hypoxia, you are thinking about the oxygenation status of the tissue, right? So to understand who is affecting that state of oxygenation of that tissue, we should know the factors. Those factors we have to know. So for example, I take an example right now, hypoxemia. So if I take the first factor, that is hypoxemia, this is the first factor. In hypoxemia, what is the main concept of hypoxemia is you have a decreased PaO2. Now tell me, is it talking about the alveoli or is it talking about the arteries? Is it talking about the arteries or is it talking about the alveoli? It's talking about the arteries. So whatever is the arterial blood gas, that ABG will tell me that because what is an ABG? We are taking a sample. Normally, when you are taking a blood sample, you are taking from vein, isn't it? When you are taking a blood sample, for example, a doctor recommends you a CBC. He recommends you a CBC, and the technician he comes, or the nurse, she takes the one she takes your blood sample from your what vein, isn't it? But in case of ABG, the arterial blood gas, I am more concerned about the pH. I am more concerned about the bicarbonates. I am more concerned about the carbon dioxide in that, the saturation. So that can only be available, that I can only know if I can take the samples from the arterial vein, artery. I have to take the artery. So I usually radial artery or femoral artery I take, because why we don't take a sample, sir? Why we don't take sample from an artery every day? Why we take vein? Because artery is a very high pressure system. Artery is a very high pressure system, and if you start puncturing, if you puncture it with your needle and you are drawing the blood, okay, you will get the blood, but once you leave it, there may be a blood loss, because can you see the arterial pressure? Okay. So we don't go for arterial punctures. We go in arterial punctures for special cases. This requires a very specialist person who can do the ABG. Okay, this ABG analysis and all that. It is his work. So I'm here concerned because I want to see, because artery supplies the blood to the tissues. So I will be concerned that what is the oxygenation, what is the oxygenation of the blood cells also, which are carrying the oxygen to the tissues. So if I am decreasing the PaO2 in any somehow any way, that will definitely lead to tissue hypoxia. Okay. Now that means this PaO2 which we are talking in the blood vessel, that will indirectly depend. No, not indirectly. Actually, it will depend on the uh, inhaled oxygen also, because you will inhale the oxygen and it will come into alveoli. And if you are not bringing any oxygen here, you are not, the decrease is a decrease in the oxygen. So what will happen? You won't be getting the PaO2 also. That will affect this. Okay. And now you understand from your physiology, there was a VQ ratio. There was a VQ ratio, ventilation perfusion ratio, ventilation perfusion ratio, isn't it? You have read about the lungs that, you know, the amount of those, you know, the blood flow and your inspired air, that should match. That should match, isn't it? So this ventilation perfusion VQ ratio will also affect the hypoxemia. Okay, and also the status of the places here. This we take these things lightly. People don't think about. You have to think about this thing. That is this space very much compliant for the diffusion of oxygen? Is this place very much compliant for the diffusion of oxygen? There should not be any sort of a fibrotic scenario. No, fibrosis has happened, pulmonary hypertension, or I can say, you know, pulmonary edema, because that will affect the oxygenation, the diffusion of the oxygen. Okay, so these are the things you have to think when you are thinking about the hypoxemia. Now, it will also depend on the partial pressure of the, you know, the oxygen present in that atmosphere. Okay, the hypoxemia is causing hypoxia, isn't it? Hypoxemia is causing hypoxia, isn't it? Yes, guys, isn't it? Hypoxemia will lead to hypoxia, because hypoxia is the tissue status and hypoxemia is the dissolved oxygen, that partial pressure of the oxygen in the arterial blood. So if I talk about the respiratory acidosis, what is respiratory acidosis? Now see, I am breathing through my lungs, and the only source of oxygen and can be the lungs, isn't it? It's only the inhalational way. If I am retaining more carbon dioxide in the lungs, that means I am doing hypoventilation. Now see, I will make you listen a sound. See, one is one is like this. Let me bring the mic closer. One is like this. This is normal breathing. This is normal breathing. Now see what I am doing. I'm going to do. See. This is called hyperventilation. This is called hyperventilation. Now I show you hypoventilation. Am I retaining the carbon dioxide or not? Am I giving more time to the carbon dioxide to remain inside my body? Isn't it? Am I giving, guys, are you able to understand? This is so simple. So once I'm not allowing the carbon dioxide to come out, what will happen? It will get retained. Will it cause the increase in the PaCO2 when I'm not throwing it out? Will the PaCO2 increase? Will the PaCO2 increase? Can I say if I have a PaCO2 decrease in the PaCO2, can I say I have a, correspondingly, to that I will be having a decreased PaO2? Can I say in the blood the partial pressure of the oxygen will fall because of the increase in the partial pressure of the carbon dioxide? When you are increasing one quantity, the other quantity will get down. When you are increasing one quantity, other quantity should get down. That means the PaCO2 is increasing, meaning thereby PaO2 should decrease. PaO2 should decrease correspondingly. How will you understand? So what can cause a respiratory acidosis? For example, I am on a barbiturate therapy. Okay. You know that barbiturates from the pharmacology, that it causes what? The respiratory center depression. Okay. Or someone is having any neurologic disease, for example, ALS. What is ALS? ALS is amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis. Okay. What is happening in this is that, your diaphragm, if I take a diaphragm, your diaphragm is supplied by what? Phrenic nerves, isn't it? So a diaphragm is supplied by phrenic nerve. What happens? This phrenic nerve, it is a nerve, and what happens if I am having any sort of a sclerotic, any sort of a thickening? Okay, I have a nerve disease. Can my diaphragm work? Can my diaphragm work? It won't work. It can't become flat. It can't become flat to inspire the oxygen, and it can contract too. Basic thing is about the making it a flat shape from a dome shape. It's actually a dome shape. You have to make it flat. So you need a motor, you need a motor impulse so that you can initiate this thing, isn't it? Or you have chronic bronchitis, a COPD, a chronic bronchitis. You have a chronic bronchitis patient who can't expand his lungs. He can't expand his lungs. He has inflammation. So what he does not. It's like, huh, like this. Yeah, he can't breathe more. Okay, is it clear? So can these things lead to respiratory acidosis? So once you are retaining the carbon dioxide, that will, because carbon dioxide will finally give me what? Proton. I think you understand, you have learned it in the physiology. So once you have more protons, you will have more acid. So indirectly we say carbon dioxide is an acid. Indirectly we say carbon dioxide is an acid. So can I say it has led to respiratory acidosis? It has led to respiratory acidosis. So this is just a correlation. I will be teaching the respiratory acidosis in, I think, in the respiratory pathology, okay, and also in medicine, how to read an ABG, how will you diagnose a patient? Is he having respiratory acidosis, respiratory alkalosis, metabolic acidosis, metabolic alkalosis? So always, and from the concepts that once you have respiratory acidosis, your body tries to compensate this acidosis. It will try to produce more bases, bicarbonates. So who comes to the rescue? If you have on one side respiratory doing acidosis, who comes to the help? Kidney. Who comes to the help? Kidney, your renal. What it starts to, it starts to produce more bicarbonates. These are actually friends hand in hand. These are friends hand in hand. Who? Friends hand in hand. Who are the two friends? Lungs, kidney. What are they doing? If one person is doing acidosis, this person will start producing base to maintain the normal body pH. Homeostasis. Homeostasis. Are we able to understand? Now you are at an, for example, you are living, you reach to a mountain, okay, you reach to the tallest peak. Will the inspired O2 get decreased or not? Will the partial pressure, is the partial pressure of oxygen less or not? Can I say it can lead to respiratory, can I say I will have, the partial pressure of oxygen is less, then the diffusion of the oxygen will be less, that meaning thereby that I will have more PaCO2, meaning thereby I will have more PaCO2. So you can think the two things in either way. You can think the two things in either way. Okay, I will understand. By the way, how much is the V by Q ratio? Can someone tell me what is the V by Q ratio normal? You don't need to remember. You don't need to remember. You don't need to remember. This is Q. I remember it by 8. Okay. And I remember like this. It's 0.8. So how to calculate? It's simple to calculate. Why to remember? Sir, what is the V? What is V? V means ventilation. Whose ventilation? Whose ventilation? Alveolar ventilation. That is what you forget. It's about the alveolar ventilation. How much is the alveoli getting ventilated? The flow. Okay. Now, alveolar flow divided by perfusion flow, that is the pulmonary blood flow. Pulmonary blood, isn't it? We are sending the blood to the pulmonary system. So divide it. What is the alveolar ventilation? 4 liters per minute, isn't it? And what is the amount of blood? 5 liters per minute. So calculate, it's 0.8, isn't it? Is it 0.8 or not? I don't think my mathematics is good, so you should check it. Okay, so 0.8 is V by Q. Okay, is it okay? And there was also a concept that we describe. One is a V by Q ratio, another is a normal V by Q ratio. That means what? All your other things should be nice. Your tidal volume should be nice. Your cardiac output should be normal. Then we can say this. There's a normal. The normal V by Q, 4 by 5, 0.8. Okay, is it clear? Now, which things can lead to this? If I have a V by Q ratio disease, which things can cause a V by Q defect? We say VQ defects. So which things can cause VQ defects? Let us integrate it here. Yes. Sir, you should classify, you should directly tell us. It can be a V defect or it can be a Q defect. It can be a V defect, it can be a Q defect, isn't it? Either it's a ventilation defect which is leading to the abnormality of hypoxia, or it is a perfusion defect. Now in ventilation defect, what is happening? Ventilation defect, that means in the ventilation defect, let me write. In the ventilation defect, you have a ventilation defect. That means your blood flow is normal. Q is normal. That means your blood flow is normal. Ventilation is defect. So that means alveoli is getting a very nice blood supply. Alveoli is getting a very nice blood supply, but the problem is in the ventilation, the flow of the oxygen. Okay. And now, what is ventilation? Who can lead to ventilation defect? Sir, there can be some things should be thought which are not allowing the oxygen to reach the alveoli. I am not allowing the oxygen to reach the alveoli. That's why I am telling that I have a ventilation defect. For example, I have any type of a, you know, respiratory distress syndrome, RDS, respiratory distress syndrome, respiratory distress syndrome. What is it? What is happening in that? There is a shunting of blood. Intrapulmonary shunting is happening. You don't have, in respiratory distress syndrome, what is the problem? We don't have surfactant. In respiratory distress syndrome, we don't have surfactant. Surfactant will decrease the surface tension. So if your alveoli, see, once you're expiring, your alveoli, they should come closer, isn't it? They should come closer. Once you're expiring, the thing should come together. And once you're inspiring with a little oxygen, it should expand. It should expand. Who is doing that? Who is helping in that? We are using the surfactant. Surfactant is things like a liquid thing in between the things. Okay. So this is actually decreasing the surface tension. So when it is decreasing the surface tension, it will keep the alveoli in an expanded form. It will keep the alveoli in an expanded form. Can I say my surfactant prevents atelectasis? What is atelectasis? Atelectasis means collapse. If your distal airways, the end airways are getting destroyed, are getting collapsed, not destroyed, actually collapsed. Can I say it is a atelectasis? That is what is happening in the respiratory distress syndrome. A patient of respiratory distress syndrome does not have surfactant. SPA, SPA, SPB, SPC. I hope you have read it in the biochemistry. What is happening? This sort of a lubricant is not present there. Once you have no surfactant, you will have no decrease in surface tension. You will not allow the lungs to remain expanded. You will let them to collapse, leading to atelectasis. Or you have cystic fibrosis, another disease which can cause this ventilation defect. Cystic fibrosis. What is happening in cystic fibrosis? It is all that chloride business in happening in the CF I will be teaching in the respiratory pathology. So in short here, remember for this point of time that cystic fibrosis, you can see there is production of a thick mucus on the lumen. On the luminal side, there is a production of thick mucus plug. Now tell me one thing, if you have this airway and this airway is producing thick mucus plug, will you allow the diffusion of the will you allow the diffusion of the things? Will you allow the diffusion of the things? If you have thick mucus plugs on the airway, will you lead to will you finally lead to the atelectasis, isn't it? So in the cystic fibrosis, that is also, so you should remember two things, that is respiratory distress syndrome, where I have a decrease in the surfactant, and that surfactant will lead to the decrease, that surfactant will not decrease the surface tension, but will actually lead to the collapse of the distal airways, leading to atelectasis. And another example which you can think is the what to say, what was the other example I gave you? Cystic fibrosis, where you can see thick mucus plugs blocking your airways, and they are not letting the alveoli again. That again an atelectatic scenario. Okay, so this is what you have to remember. I don't want to give more examples because we have to learn it in the respiratory pathology. But here, to make you understand that what things at what levels we can have hypoxia defects, we can have ventilation defects. Okay, now I'm giving you two examples. Why? Because we have to read all this in detail, so we have to just mention in the points here. so that we can very nicely understand the concepts of pathology. So if I talk about the perfusion defect, if I talk about the perfusion defect, in the perfusion defect, perfusion means that blood flow is not happening very nicely to the alveoli. That means ventilation is normal. Ventilation is normal. Ventilation is normal. That means I have decreased the blood flow of the perfusion of the alveoli. For example, I take a vasculature. This is, for example, the vasculature of the lung. For example, I'm drawing one or two, three vessels. What is happening is this is the pulmonary. This is the pulmonary artery. Okay, let me draw the heart. This is the right side of the heart. Okay, this is the right side of the heart. Okay, this is the right atrium. This is the right ventricle. What is happening is I am draining the things from the inferior vena cava. The things are coming in the right atrium. Okay, and from the superior vena cava, the things are coming in the right atrium. Superior vena cava is collecting the blood from the superior regions, upper regions of the body, while inferior vena cava draws the blood from the inferior regions towards the heart. So things are coming here. Now I think of a case that is the DVT, deep vein thrombosis. I think of a DVT. You know what happens in DVT is I have a small clot in the leg veins. For example, this was the leg vein and I have a small clot. Now this small clot, once I am having the venous return during the inspiration, isn't it? In the inspiration, I have a negative intrathoracic pressure and I bring all the blood from the peripheral part of the body towards the central part, isn't it? So things are coming more towards the things are coming more. The venous return is increasing. The venous return is increasing, my dears. Venous return is increasing. Now, is this clot also coming here? Yes, sir, it is coming. This clot passes through the tricuspid valve and then comes here in the right ventricle. I'm showing you, see the timeline, showing you even where it is going. So see, moving, okay, just moving. Yeah, now the game starts. Okay, this was a big vessel, no problem, no problem, no problem. But see, now the problem is going to happen, my dears. Yeah, the narrower the vessel will become, it will start lodging in that. Now, can you tell me, has it blocked the blood supply? Has it blocked, my dears? Has it blocked the blood supply here? Can I say this is a pulmonary embolism? What is an embolus? An embolus is a migrated thrombus. If a thrombus gets migrated, we say it is embolism. So has it reached to the pulmonary system? Can I say it's a pulmonary embolism? Pulmonary embolism. Can I say this pulmonary embolism is actually decreasing the blood flow? Can I say pulmonary embolism is causing ischemia? Can I say pulmonary embolism is causing ischemia? Can I say pulmonary embolism is finally leading to hypoxia? Now, if they ask you a word hypoxemia, is it possible? Is it possible that pulmonary embolism can cause hypoxemia? Right now, is it possible that hypoxemia is happening? My dears, how is this happening? How it is happening? This minor is not hypoxemia. I'm talking about the hypoxemia in that way, the oxygen saturation. Right now, the oxygen was well saturated. I'm not saying that. I'm saying will it in the end it will happen. That will happen. But can it will happen? Definitely it will happen. But right now I'm telling you, you should be concerned right now about the hypoxia first. Hypoxia, because you will not be able to deliver the things. Okay, and then also hypoxemia will also happen. Okay, you can take the both things, but I am telling you any defect which is leading to the decreased in the oxygen supply to the tissues, you should think of hypoxia instead of hypoxemia. And then after that thing has got hypoxia, you can think after that maybe hypoxemia will happen. If it is a lung, if it is a lung, hypoxemia will happen. Are we able to understand? So any sort of, now what happens, I will give you another scenario from the orthopedics. I have a patient and I am in the, for example, in the ER. Okay, the patient is coming to me with road traffic accident. He has a fracture femur. He has a fracture femur. Okay, femur fracture. Now tell me one thing. Now today, right now, it is 10 a.m. and add it 24 hours. So after 34, at the 34th hour, the patient is telling me, I am developing. Now he's in the hospital. We are fixing his legs. We are fixing his legs. It's an important case. Please mention it on the copies. You will be needing this case in the orthopedics. So what will happen? The patient is coming to me after 48 hours. He's telling to me, doctor, he calls me. He says, doctor, I'm on this bed. Okay, I go there. He says, I am feeling some sort of respiratory distress. Oh, I check his saturation. His saturation is also affected. I check his fingers. His little bit of, getting towards the cyanosis of paleness and something. As being an orthopedic pedician, or as being an orthopedic surgeon, or as being a internee, what should I do? I should suspect at that time that it is a fat embolism. The fat droplets, once the fracture has happened, once this fracture, this is the bone. This is a bone. I have drawn a tooth, I think. It's not a bone. Okay. So if I draw it like this, let me draw like this. So this is a bone, for example. Just depicting the schematic diagram. So I have a fracture. I have a fracture here. So the mostly he's an adult, so he should have more of the fat tissue in his bone marrow. So what is happening? These fat droplets, once they fracture, they will diffuse into the blood circulation. Now this fat will travel this droplet. Can it lead to the embolism? That is called the fat embolism. We will be learning in the hemodynamic pathology. So this is the concept, that fat embolism. Can it decrease now? Can it decrease the perfusion? Can it decrease the perfusion if I have like same the fat embolism? So that will lead to, you should remember this case for your life. You can't miss this case. So he is a patient who has developed the fat embolism. Okay. So will this problem, if this problem is happening, will it lead to the decrease in the O2 CO2 exchange? Because here are the pulmonary capillaries. This is your arterial system now. This was the venous system, isn't it? This was your venous system. This was all your venous system. Now, will you finally decrease the O2 CO2 exchange? Will you finally decrease to O2 CO2 decrease? Okay. There is a concept of the dead space, isn't it? Your dead space will increase in this, isn't it? Your perfusion defects produce what? Pathologic dead space. It will increase in the pathologic dead space. So, meaning thereby, I want to say in short that you will have both degrees of, what to say? You will have decrease. If you have perfusion defect, then you will have what? PaCO2, PaO2, both will decrease. Why, sir? Why PaO2? PaO2 is decreased because you are not taking oxygen. You are not having perfusion. Don't have things. You don't have things which can take, because once you are, all of this depends on the blood flow. All of these things depends on the blood flow. You are not sending the blood there. Who can collect the oxygen? There is no exchange. So that's why we are seeing both things get decreased. Sir, why PaCO2 is decreasing? This was about PaO2 because we are not able to exchange. Why PaCO2 is also decreasing? Because patient will naturally cause what? He will go into hyperventilation. Once he has reaching the acidosis, he will start hyperventilating, isn't it? As a normal homeostasis. Why? Because he wants to throw the carbon dioxide out. His pH is getting towards the acidic side. So what he will start hyperventilating. He will breathe faster. So what will happen? That will decrease the carbon dioxide, isn't it? So remember, in the perfusion defect, I have both decrease. I have both decrease. Are we able to understand, guys? Okay. Now I tell you another scenario. See, I have connected this to so many things so that you can understand at what levels hypoxia can happen. Okay. This is actually the integrated pathology, which is now the requirement of every entrance examination, be it USMLE, labs, be it any exam of your country, South Africa, anything. This will be the exam. They will ask you everything in integrated manner, and a doctor should be able to integrate things. If you are not able to integrate things, you can't think of a case. How a pathology is happening, there should be a mind map which should be working in your brain. That will only be possible once you understand the concepts. If you learn concept, there is one thing. One thing is there, you start mugging up the concept and you then start vomiting that in the hospital, and then you don't get to any point. Another thing is you are conceptual. You are thinking this fat embolism is coming from this DVT comes, it comes in the venous return, it is there. This is a concept, this is a map you should have in the brain. Once you are learning some notes, then God bless you. Okay, God bless you. Note reading will never help you. We are doctors. We don't believe in anything. We believe in books. We don't believe in any shortcuts. If you have any shortcuts, good for you. Good for you. Really good for you. But we don't in the hospitals. We can't give a patient to such a person that who has learned a note and he can't even undiagnose a simple disease. That is only possible once you're reading the textbooks. Read a standard textbook, things will start becoming easier. Okay. Now, if I talk about the diffusion defects, there can be diffusion defects also. If I have talked about the V by Q defects, there can be diffusion defects also. What is happening is everything is normal. Everything is normal. Blood vessel is normal. No, blood vessel is normal. And oxygen, saturation of oxygen is also normal. The PaO2 is also normal. But what is happening? Not PaO2 actually, the partial pressure of the oxygen in the atmospheric partial pressure of the oxygen is normal. Perfusion is normal, no pulmonary embolism, no fat embolism, no thrombosis, no occlusion of the blood vessel, no saddle embolus, nothing. So if I'm talking about this diffusion defect, so what is happening? Oxygen perfusion is normal. Ventilation is also normal. Ventilation is about, what is ventilation? It is the status of alveoli. Ventilation will tell me the status of alveoli and all the respiratory tract. Perfusion will tell me the status of the heart, status of the blood vessel, how much blood is going towards the lung, how much is getting that oxygen is getting diffused into the blood. So that will all depend on my diffusion and perfusion. Now I'm telling you there is now everything is normal, but what is happening that oxygen is not able to come into the blood and carbon dioxide is also not able to diffuse. So what is happening? I say it is a diffusion defect. It is a diffusion defect. Why this is a diffusion defect? Because everything is normal. Again, everything is normal. Diffusion is not happening. That means there should be someone at that place who is stopping the diffusion of the oxygen, who is stopping the diffusion of the carbon dioxide. Oxygen diffusion from the alveoli towards the blood vessel. Carbon dioxide diffusion from the blood vessel towards the alveoli. So I will say two examples. The example is interstitial fibrosis. Interstitial fibrosis. I am telling you there is a fibrosis. Interstitial fibrosis. I have a fibrosis here. Fibrosis is happening. Think like a fiber. Okay, let us take like that. Scarring is happening. Will the things diffuse? No, you have built a wall. You have built the wall at the interface of alveoli and blood vessel. Second thing, if I have pulmonary edema. Now what is pulmonary edema? In the pulmonary edema, if I take the heart, these are the four chambers of the heart. From the left side, for example, there is what to say. I have a left heart failure, for example. I have a left heart failure. Left heart is not pumping. That means the diastolic function is lost. If I have a diastolic left heart diastolic function failure, left heart diastolic function failure, LHDFF. So what will happen? Things will start building up. First, the pressure will rise here because he's not pumping. He's not pumping. Now the left atrium will also increase its pressure because diastole is not happening. Isn't it? My dears, the systole is also not happening. Diastole is also not happening. So what will happen? Now it will start building up in the pulmonary. Yeah, pulmonary system. Isn't it? So will the pressure of the fluid start increasing? Back pressure, back pressure, back pressure. Will it lead to more production of transudate? Will it lead to more production of transudate? Why transudate? Because there is high hydrostatic pressure. Hydrostatic pressure is increasing. We said in the law of those pressures, we said that we have hydrostatic pressure of the blood vessel, hydrostatic pressure of the interstitium, isn't it? We said oncotic pressure of the blood vessel, oncotic pressure of the interstitium. What is happening here is the hydrostatic pressure is dominating. Hydrostatic pressure of the blood is dominating. That means you have more pressure in the pipe. That means you will start leaking from the walls. You will start leaking from the walls and you will have more fluid around this interface. So this interface will have more fluid. So will you allow, if I have more fluid, will I be able to diffuse? No, it will be acting as a barrier, isn't it? So diffusion defect, there will be, the example can be interstitial fibrosis, pulmonary edema, which is leading to a diffusion defect. Everything is normal. Ventilation was normal, perfusion was normal, but the problem was at this interface, which led to the decrease in the oxygen and then the hypoxia and then the cell injury. Then the cell injury. Or you have TOF, or you have TOF. What is TOF? Tetralogy of Fallot. Tetralogy of Fallow. Tetralogy of Fallow. What is happening? Tetralogy of Fallow is there is a RL shunting. There is a RL shunting of the blood. It's actually a congenital heart disease. What is happening? The blood is getting shunted, where all the venous blood is shunting from the right ventricle into the left ventricle. That's why we call it a right to left shunt. Now tell me one thing, my dears. This is the place it has a shunt here. Ideally, it should have been like this. Ideally, these four chambers should had been like this. But what is happening? There is a right to left shunt. For example, there is a right to left shunt like this. So tell me, this is the venous blood. This is the pure blood. Now, is the venous blood getting mixed in the left side of the heart or not? My dears, this venous blood is getting mixed into the right side, left ventricle. Now tell me, left ventricle has the function of pumping the blood towards the peripheral circulation. Now tell me, will it throw that also the less saturated oxygen blood to the circulation? Will you have a drop in the PaO2? PaO2. Will it lead to the decrease in the PaO2? Are we able to understand? So can I say that it's actually this mixing which is leading to the PaO2? Okay. Okay. I'm just giving here an example. I will be teaching you the heart disease. I'm just showing you how things can mix. Or we had Eisenmenger syndrome also. I will be teaching you that in the heart. Okay, in the heart pathology. So all these factors, we are learning how the factors, how hypoxemia. This was all about hypoxemia, and the diffusion of all these things which are leading to the decrease in the oxygen. Once you have a decrease in the oxygen, you will have less oxygen reaching to the tissues. That means hypoxia. What is hypoxia? The adequate oxygenation. Is the oxygenation of the tissue happening adequately or inadequately? So we have finally led to the hypoxia. That is why we are studying the cell injury. We have known every pathology. Now we can very nicely understand, how things will happen, what can cause. Now tell me one thing. Can I relate this hypoxemia? Can I say also the ischemia is itself the factor? Or you say in your country ischemia. So can I say this ischemia is actually the factor, itself a factor for causing the hypoxia? Yes, sir. Why not? Because ischemia, the definition is decrease in the arterial blood. This concept should be known. Decrease in the arterial blood supply to the tissue. Now, one thing, please. You only think of arterial right now. Right now, thinking of arterial. Decrease in the arterial blood supply to the tissue will lead to the hypoxia. Very nice. Now, I give you an example. This is a tissue. This is the artery. This is the artery which is coming towards the tissue. And this is the vein. This is the vein which is leaving the tissue. Which is leaving the tissue. Now, tell me one thing. What if I bring a thrombus here? What if I fix a thrombus here? What will happen? Will the venous blood get built up? Will the venous blood get built up? Please, I want answers from everyone. It is a live classroom. Anyone can answer. I want answers from everyone. Everyone. Are we able to understand the concept? If I am bringing, can I say this is also ischemia? Can I say this is also ischemia? Why, sir? Because I am building more venous blood. Because I'm increasing now I'm increasing the less saturated blood levels. This oxygen was taken up by the tissues. Once the oxygenated blood was coming from this side to this side, oxygen was taken up by the tissue, and now it had to leave the blood. It had to leave this tissue through the venous circulation. But what is happening? I am now increasing the impure blood. I am now increasing the less saturated blood, less oxygen saturated blood in the tissue. Will definitely affect the hypoxia. Will definitely lead to inadequate oxygenation of this tissue, and finally hypoxia, and finally cell injury. Let us give you an example. Your heart, if you take your heart, I draw something, an anatomical heart. So, so if I draw, this is your right side and this is the left side, okay? Yes, very nice. Okay, yeah. Very nice, Fabina. The oxygen will get, shortage of oxygen will happen. That's what is happening. The venous return is not going, isn't it? The blood is not going towards the heart. It should go towards the heart in an ideal venous return mechanism, but it is building up in that place, leading to the decrease oxygen saturation at that place, at this place only. We are talking about this place. Not lungs are not doing anything. The problem is here. We are not letting the gate to open. The gate is closed. So are building up the oxygen unsaturated blood or less saturated blood in this tissue. That is also hypoxia. But you are always thinking of ischemia of the arterial scenario. No, it is the venous also. So what is happening? This is the, for example, this is the AV node. Okay, this is the AV node. So this AV node, now this is the SA node. Okay, at the opening of the superior vena cava. If I make the blood supply, the things are like this. There is a right coronary artery, and it is then turning at the back, isn't it? Right coronary artery. This is the left circumflex artery, and this is the left anterior descending artery, and then they are going to the base. This is the circumflex and reaching the back. So can I say if I have a thrombus, if I have a thrombus in with one of the arteries, okay, if I have a thrombus, for example, if I have any coronary artery disease, CAD, okay, can I say it will lead to the less oxygen? Now the blood can't come. It is ischemia. Blood is not going towards this place. Will the right ventricle get the blood? No, sir. Right ventricle will not get the blood. Will it lead to the decreased hypofunction of the right ventricle? Yes, sir. It will lead to the hypofunction of the right ventricle. Will it affect? Will it affect the cardiac output? Yes, sir. It will affect the cardiac output. Will it finally again lead to ischemia? The ischemia to this organ, will it again lead to ischemia of the lungs? Because right ventricle is not now pumping. It's not getting the blood supply. Guys, what's up? Please answer. Okay. This is the reason what ischemia can do. Okay. So will it lead to the infarction? That's why you call myocardial infarction. Myocardial infarction. We'll be reading the infarcts, don't worry. Okay. Just giving you an orientation. So will it compromise the metabolic functions of the cell? Compromisation of metabolic functions of the cell. Okay, guys. I hope you are understanding the ischemia and hypoxemia very nicely. If you are going now to a altitude of greater than 10,000 above the sea level, okay, you are going above the sea level. Okay, you are going above the sea level. What will happen? You know your atmospheric pressure is getting less, meaning thereby your alveolar PaO2. Can I write like this PaO2 capital? Can I write like this capital PaO2? That will also decrease. Now what will happen? What will happen if this scenario happens? You have to remember like this. What will happen? Sir, 4 or 5 things can happen, isn't it? What can happen if I start from the above to below? You have to learn like this. See, look at your body and think what will happen. First think of the lungs, because it's all our concerned about the oxygen, so we should think about the lungs. What can I think about the lungs? If I have a decreased arterial O2, not arterial, sorry, alveolar, A capital is for alveolar. We have told you in the last lecture. Will your body naturally, you have now decreasing the PO2, will it lead to the corresponding increase in the PaCO2? Will it lead to the corresponding increase in PaCO2? Very nice, very nice. It will lead to the corresponding increase in the PaCO2. Now, who will sense that? The respiratory centers will sense that. They will say, oh, the oxygen is not going. The oxygen is not there. PaCO2 will increase. PaCO2 will increase. So what will happen? Will you hyperventilate or not? Will you hyperventilate or not to throw that carbon dioxide out? So this will lead to hyperventilation. That is why once you are going about 10,000, you are doing this is what you do. You are hyperventilating. See how much carbon dioxide I have thrown out. Talking about talking about the status, talking about the status, talking about the status. Will if my PaO2 is decreasing, if my PaO2 is decreasing, will it lead to respiratory alkalosis finally? Will it lead to respiratory alkalosis? Will it lead to respiratory alkalosis? What is respiratory alkalosis, sir? I am hyperventilating. I am throwing all the carbon dioxide out, meaning thereby my respiratory system is throwing the carbon dioxide out, means I am throwing the acid out. And we think carbon dioxide as an acid at the end producing the proton by that reaction. So I'm throwing the carbon dioxide out, and in the blood I am leading to alkalosis because carbon dioxide is thrown out. It could finally give me what? It was finally giving me acid. But I have thrown all the carbon dioxide out. Now it won't be giving me that acid. Finally, an alkalosis, respiratory alkalosis. That means your pH will increase. Your pH will increase. Are we able to understand? Now tell me one thing. Will your pulmonary resistance start increasing? Do you know the reason your pulmonary resistance, pulmonary vascular resistance increases once you have a decreased PaO2? We know that from the physiology, isn't it? Isn't it? Do we know? Do we know that concept of 2,3-BPG or not? You know, I think you have known. I will give you some hints. When you are going to the higher altitude, your atmospheric pressure is decreasing. That means the oxygen. That means the oxygen will it decrease. Will the oxygen decrease in the atmosphere? Will the percentage of oxygen decrease in the atmosphere? No, sir. Oxygen is same. 21% oxygen, same oxygen. Nothing happened. But what is happening? I am going into hypoxemia because the pressure is not so much. The pressure is not so much. I am going to hypoxemia. Once you have hypoxemia, I am talking about the physiology, giving you a physiology integration. What will happen? You will have activation of peripheral chemoreceptors. Who are the peripheral chemoreceptors? Carotid bodies and aortic bodies, isn't it? Carotid bodies, aortic bodies, both of them. I'm palpating right now on the neck. Carotid bodies, aortic bodies, they will all are the peripheral chemoreceptors. What is chemoreceptors? They are checking the chemical status of your blood. They are seeing, oh my god, you have a higher amount of carbon dioxide. What will happen? Oh my god, they will start doing increasing the respiratory rate or hyperventilation. Once you are going to hyperventilation, you are throwing all the carbon dioxide out. That is finally leading to respiratory alkalosis. Your arterial pH is getting low. Very nice. Your arterial pressure is getting, arterial pH is getting low. Meaning thereby, I am decreasing the PaCO2. Okay. Now what is happening once you are going to respiratory alkalosis? Your all the pH of the cells, they will start increasing. Oh, sir, how? They will definitely they will increase, my dears. You are not getting oxygen, then you are going where you are going. If your intracellular pH is increasing, that means you are going to anaerobic. You are going to anaerobic glycolysis. So what is happening is finally your all the intracellular pH that will turn on the switch of phosphofructokinase. I am integrating biochemistry. Phosphofructokinase. And you know from the concept of glycolysis that phosphofructokinase is the rate limiting step of glycolysis. Once you are increasing the glycolysis, this phosphofructokinase, you will lead to more production of 1 to this BPG, 1,3-BPG, which is finally getting converted to 2,3-BPG, isn't it? Now you know 2,3-BPG. What is the function of 2,3-BPG? 2,3-BPG is shifting that oxygen dissociation curve towards which side? Right. Once you, I told you last time in the previous classes, once I say 2,3-BPG is going towards right side, you know this curve. 2,3-BPG is going towards the right side. That means ODC. ODC is what? Oxygen dissociation curve. That is going towards the right side. Will lead to the release of oxygen. It throws the oxygen from the RBC. Go, 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 give to tissue, don't bind the oxygen more. Okay. Now tell me one thing. If you are having less PaO2, will your body blood vessels of the lungs, will they definitely by physiology, will they go into vasoconstriction? Why? They don't want to lose the oxygen. They want to retain more. Your pulmonary arteries, they want to retain more. They will go into pulmonary vasoconstriction. Can I say once they are getting into vasoconstricted, will it lead to increase in the blood pressure here? Here the pulmonary hypertension will happen. Pulmonary hypertension will happen. Why? Because you are increasing the pulmonary artery resistance. Will it finally lead to the increase in the pulmonary artery pressure? Will it lead to the pulmonary artery hypertension? Now this, see, check this. Now check your vision. Where will this pressure go? I am increasing the pressure here. So I am increasing the pressure, increasing the pressure, increasing the pressure, increase. This is the right side of the heart, right ventricle. This is the right ventricle. This is the right ventricle. So this right ventricle is having what? More pressure. Right ventricle is having more pressure, isn't it? Will the has the right ventricle to work more or less? Has the right ventricle to work more or less? It has to now work more because the vessel is so narrow. It has to throw the blood towards the lungs. It has to throw the blood towards the lungs. So what is happening? Will it finally lead to the right ventricular hypertrophy? Will it finally lead to right ventricular hypertrophy? This condition is called as cor pulmonale. This condition is known as cor pulmonale. What is cor pulmonale? Right ventricular hypertrophy and pulmonary hypertension. Right ventricular hypertrophy plus pulmonary hypertension is equal to cor pulmonale. Guys, the MBBS medicine is so tasty, beautiful subject. So are we able to understand how from a hypoxic scenario, the things are moving? Okay. In the next video, we will talk more further how hypoxia can happen. Okay, we are actually thinking of many things, all integrating all the body systems, and that's how we can learn things very nicely. I hope you enjoyed this lecture. If you have not subscribed to my channel, please subscribe. It's Dynpaths, a new channel. We will be giving you all the pathology, all the explanative pathology you need at your undergraduate level and also for your licensing exams. I hope this definitely helps you all. It's actually a free initiative to help the people who are not able to understand the subject. Uh, and thank you for your patience and time. Have a nice day. God bless you.